Good afternoon, everybody. Welcome to everyone who's joining us here in the DC office and the some 200 or so who are joining us by webinar. My name is David Stapleton. I'm the director of Mathematica's Center for Studying Disability Policy, and this is our policy forum on disability and well-being, barriers to improving quality of life for people with disabilities. The Center for Studying Disability Policy was established in 2007 to help build the evidence base for sound, effective disability policy, and findings from our center's research can help inform disability policies and programs across the nation to better meet the needs of all Americans with disabilities. One way that we do that is through these disability policy forums. We really want people who are interested in disability policy, as I'm sure you are, to be aware of the research we're doing and its implications for disability policy. Before I get started on the forum, I want to alert those of you who might be graduate students, and I know there's at least one here, to a summer opportunity, Mathematica's Summer Experiential Learning Fellowship in Disability Policy. It's sponsored by the Social Security Administration through our Disability Research Consortium agreement with that agency. And the program provides graduate students an opportunity to learn more about disability policy issues and the conduct of disability policy research through the summer in Mathematica's setting. So we are now accepting applications through February 13th, and you can visit our website to get more information. So the goal of Mathematica's Center is to inform disability policy and to provide evidence that can help policymakers design, implement, and manage policies and programs that efficiently help people with disabilities to achieve meaningful quality of life outcomes, social and emotional well-being. To achieve high quality of life, every human being needs the support and resources to define how they want to live their lives, as well as the opportunity to form close relationships, participate in their communities, gain meaningful employment, and enjoy the right to dignity and privacy. People with disabilities are different only in that they face special challenges as they strive to achieve that same high quality of life that everybody wants to have. So our speakers today are going to focus on various aspects of these challenges and how current disability programs help shape the quality of life for people with disabilities. So the first speaker is going to be my colleague Priyanka Anand. She's going to present new statistics on the extent to which disabilities reduce the time that adults with disabilities have to pursue jobs and other social activities. Next, my colleague Jody Schimmel-Hyde is going to present new information on the ability of workers with disabilities to obtain adequate and timely health care, something that is important for many of them. And then finally, my colleague Gina Livermore will present some statistics from a national beneficiary survey concerning why some recipients of Social Security disability insurance benefits live in poverty despite their receipt of benefits. We're very pleased to have with us today John Chida, the director of the National Institute on Disability and Rehabilitation Research, to offer his insight and perspective on the findings and their implications for improving well-being for people with disabilities. Prior to joining NIDR in 2014, this year earlier, John spent the last 15 years at the Courage Center and later Allina Health in Minnesota, directing public policy and research to improve the lives of people with disabilities. Over the years, NIDR has provided extensive support for our Disability Center's research activities. In fact, they supported the first two presentations you're going to hear today, and we're extremely grateful for that support. We've tried hard to prove ourselves worthy of it, and we hope that it's going to continue as NIDR makes its transition from the Department of Education's Office of Special Education and Rehabilitative Services to the Department of Health and Human Services Administration on Community Living. Before we get started, just a little bit of housekeeping to help ensure that the highest possible sound quality for our webinar participants. We ask everybody in the room that you silence your electronic devices now. This is the time to do it if you haven't already done it. Please also note that we are video recording today's session, and we may capture images of some of you, the back of your head most likely, in the audience. The video is going to be posted on our website along with the presentations in about a week. so you can go see the back of your head. And at the conclusion of the presentations today, we are going to entertain questions from both the in-house audience and our webinar audience. Now, for those of you participating via the web, please submit your questions electronically through the Q&A panel that's on your screen. You can do that at any time, and we will alternate your questions with those from our in-house audience. Please also indicate your name and affiliation, institutional affiliation, so we can identify you when we read your question. So now I'm very pleased to turn it over to our speakers, who will be much more interesting than me. So let's start with Priyanka.
Well, thank you all for joining us today. Today I'll be presenting a paper on how working age people with disabilities spend their time, and we'll be presenting new evidence using the American Time Use Survey. This is co-authored work with my colleague, Jonathan Benschelom, who is here in the audience today. The motivation from this paper arises from the hypothesis that people with disabilities may spend more time on health-related activities and other routine activities than people without disabilities. They may need more time for health-related activities because their health issues may require more attention. In addition, routine activities such as housework or personal care may take people with disabilities longer to complete depending on their disability. So because they're spending more time on health or other routine activities, this may steal time from other vital activities such as paid work. So the entire distribution of how people with disabilities spend their time may be very different than individuals without disabilities. Surprisingly, the existing literature on this topic is limited. There are some papers that look at how people with disabilities spend their time, but none of them get exactly at the question that we are interested in. For example, some of them focus on a very narrow definition of disability. So, for example, there are papers that just focus on individuals who have traumatic brain injury, for example. Others just look at a few select time use categories. So, for example, they only look at how much time is spent on health-related care. And finally, some focus on a different population than the one that we are interested in. For example, only males with a work limitation or individuals from Spain. So none of these papers really get at the question that we are interested in answering. The goal of our paper is to examine the association between disability and time use by using a broad definition of disability and looking at a variety of different time use categories that go beyond just health-related care or just 2 or 3 broadly defined time use categories. We also want to use both of the commonly used definitions of disability. So these would be the 6-question sequence on disability in the American Community Survey, the ACS, and also the work limitation question. And I'm going to go a little bit later in the presentation to more detail about specifically what these definitions are and how we use them. We also want to look at time use separately for men and women, because we do know that men and women tend to use their time differently from each other. And finally, we want to control for other observable characteristics when looking at how people with disabilities spend their time, because we know that the observable characteristics of individuals with disability tend to differ from those without disabilities, and that these different characteristics may affect their time use. So to answer these questions, we primarily use data from the 2009 to 2012 American Time Use Survey, or the ATUS. The ATUS is administered to a subset of individuals who complete the Current Population Survey, or the CPS. These individuals are asked how they spent their time from 4 a.m. the previous day before the interview to 4 a.m. on the interview day itself. So we get the time use category, or the time use information from the ATUS, and then we merge that with the March CPS, or the Annual Social and Economic Supplement, which will provide information about the disability status of the individual who answered the ATUS. We limit the sample to working age people, so these are individuals ages 25 to 61. And we exclude individuals younger than 25 to avoid looking at the time use of students, and we exclude people older than 61 to avoid looking at time use of people who are retired. So as I mentioned, the CPS has two sets of questions that we use to define disability. The first is the work limitation question, and this one asks whether the individual has a health problem or disability that prevents them from working or limits the kind or amount of work that they do. So one of our definitions for disability is whether they answered yes to this work limitation question. The CPS also has a set of 6 questions that are used to identify people with disabilities. And these questions are things like, are they deaf or hard of hearing, or have serious difficulty hearing, or do they have difficulty dressing or bathing, questions like that. So our second definition of disability is whether the individual answered yes to any of these 6 questions. We then use these 2 definitions of disability to create 3 mutually exclusive categories of disability. So the 3 mutually exclusive categories of disability are whether the individual whether the individual has a disability according to both measures. The second is whether they only have an ACS disability only. And the third is whether they only have a work limitation. Everybody else is categorized as having no disability. So in addition to defining disability, we also have to define the time use categories in a way that would identify meaningful differences between the time use of individuals with disability and those without disability. So the ATUS has over 400 activity codes, which is clearly too many for us to look at. So we collapse these into 15 categories that are listed here. So these include things like sleeping, eating and drinking, personal care, and health-related activities. These 15 categories account for all 24 hours in the day. So you can see that there is the last category are other activities that are seldom reported activities. So for example, civic obligations and things like that. So now that we have a definition of disability and we also have our time use categories, we can conduct our analysis. The first part of our analysis are descriptive statistics of time use by disability status. For this analysis, we just look at individuals who have any kind of disability, so either a work limitation or an ACS-defined disability. For each time use category, we calculate 3 statistics. The first is the percent of individuals who report any positive number of minutes on that activity. The second is the average number of minutes spent on that activity, but conditional on spending positive minutes on that activity. And the third is the unconditional mean number of minutes. So it's the average number of minutes spent on that activity, but it includes people who didn't spend any time on that activity. So this first analysis is useful to see if there are observable differences in the time use between individuals with disabilities and those without. But the problem with looking at just means is that there are characteristics that are correlated with having a disability and also affect how one would spend their time. So an example of this is that individuals with disability are less likely to have children than individuals, or young children than individuals without disabilities. So this means that individuals with disability are less likely to spend time on childcare. So another question that we'd like to get at is, conditional on having a child, are individuals with disability less likely to spend more or less time on childcare? So we answer that type of question through a regression analysis. For the regression analysis, for each time use category, we run a regression of the number of minutes spent on the time use category on having a disability. And we control for all of these characteristics such as age, race, education, etc. So the main variable of interest, or the main dependent variable of interest, is the number of minutes you spend on the activity. And then on the right-hand side, we have a dummy variable for whether you fall into each disability category. So what each variable tells us is it tells us the average number of minutes spent on that activity for someone who has that type of disability, or falls in that disability category, compared to somebody who has no disability. So before we show any results, this graph shows a breakdown of individuals with disability into the type of disability, or the disability category that they fall into. And we do this by each year of the survey that we use, so 2009 to 2012. You can see that at the top in the dark blue, dark blue, those are individuals who have a work limitation only. At the bottom, we have individuals who have an ACS disability only. And in the middle, we have individuals who have both definitions of disability. So you can see that while many people do have both types of disability, these two definitions capture different populations. That we have approximately 3% of people who have just one definition, have just a work limitation, and then another 3% that have only an ACS disability only. So these are the main results from the first part of our analysis, which are the unadjusted time use statistics. So these are the unconditional means, meaning that they include people who spent 0 minutes on the activity. And here I'm only showing the categories for which we find statistically significant differences between the time spent on the activity for individuals with disability and individuals without the disability. The biggest difference that we see is in time spent on paid work and leisure activities. So men with disabilities spend, on average, about 239 fewer minutes per day on paid work compared to men without disabilities. And for women, this number is about 171 fewer minutes. A lot of this difference can be attributed to the large percentage of individuals with disability who do not work at all. So, for example, only 25% of men with disabilities report positive time on paid work, compared to 67% of men without disabilities. We see a large substitution away from paid work towards leisure activities. So men with disabilities spend about 194 more minutes on leisure activities than men without disabilities, and women spend about 135 more minutes. So our definition of leisure includes things like watching TV, reading, etc. But I want to emphasize that we use the word leisure to capture a technical definition of leisure, and we don't intend for it to convey any assessment of the quality of time spent on leisure. On the contrary, it's likely that the time spent on leisure is not a choice, rather it's the default activity when somebody is not working. So I also want to highlight the differences in the time spent on health-related activities. So just looking at this graph, it appears, because the amount of time spent on health-related activities is much less than the amount of time spent on paid work, for example, the differences are not quite so obvious. But actually, when you look at it, the differences in time spent on health-related activities is quite substantial. So men spend about 21 more minutes per day on health-related activities, and women spend about half an hour per day more on health-related activities. And so if you add this up over a week or extended period of time, this actually amounts to quite a bit of time. So as I mentioned before, individuals with disabilities have different characteristics than those without disability, which may affect the amount of time that they spend on each time use category. So this table shows some of the characteristics that are different between individuals with disability and those without. So we can see from this table that men and women with disability are on average a bit older. They're more likely to be black. They are less likely to have a college degree, less likely to have young children, and less likely to be married. So we can control for these characteristics and others in the regressions, which is the second part of our analysis. So these are the regression results for men. The first row shows the differences in time use between individuals who have both types of disability, so both a work limitation and an ACS-defined disability. So a difference between those people and individuals who have no disability. The second row shows differences in time use between those that have only a work limitation and individuals who have no disability. And the third row shows differences in time use for those that have only an ACS-defined disability. So time use, again, as it has been so far, is measured in minutes per day. And I'm going to go through the results for males first, and then we'll look at females afterwards. And again, just like with the unadjusted results, I only show categories which are statistically significant, either for men or women. So after controlling for observed characteristics, we find that men with disabilities spend less time on paid work and more time on leisure activities and sleep. So this is consistent with the findings that we saw in the unadjusted results. But one interesting thing to note is the variation that we see by definition of disability. So as you can see, men with disabilities, according to both definitions, spend 321 fewer minutes on paid work and 142 more minutes on leisure time than on leisure activities than those without disability. But these differences are much smaller if you look at men with just one definition of disability. And in fact, if you look at those that have an ACS disability only, they spend about 47 fewer minutes on paid work, but this difference is not statistically significant. We think that this likely reflects the fact that those who report a disability measure by both measures, who report a disability by both measures have the most severe disabilities, which have the biggest impact on their time use. The results for time spent on health-related activities are statistically significant and in the expected direction, in that men with disabilities spend more time on health-related activities than individuals without. While the magnitudes may not seem very large at first, if you aggregate over the week, the amount of time is quite notable. It's about 40 minutes for men. Finally, we tend not to find statistically significant differences between men and women without disabilities on everyday activities, such as eating, personal care, housework, shopping, etc. None of these categories show up on this table. This is an important finding as well, since it indicates that individuals with disability do not actually spend more time on routine activity, or they tend not, on average, to spend more time on routine activities than individuals without disability, as we originally thought that they might. The results for women are similar to those for men. Just like for men, we see that women with disabilities spend less time on paid work and more time on leisure activities and sleep. The differences are largest for those that have both disability types. And we don't see, and they spend more time on health-related activities, and we don't see differences in many of the routine activities that we look at. So to summarize, our main findings are that working-age individuals with disabilities tend to spend about 40 to 50 more minutes per week on health-related activities than individuals without disabilities. We find few differences in time spent on activities such as housework and job search, these routine activities. However, one of the reasons why we don't find differences is that the time use data, it only tells us the amount of time being spent on these activities, but it doesn't tell us what's being accomplished during that time. So it's possible that even though individuals with disability are spending the same amount of time than individuals without disability on these routine activities, perhaps they're not getting as much done during the same amount of time. We also find that working-age people with disabilities spend less time on paid work than those without disabilities. So this is not a surprising result, given that we do see that the unemployment rate for individuals with disability is much higher than those without disabilities. So more than half of the time of the reduction in working time is offset by an increase in time spent on leisure. So again, this is not necessarily by choice. Leisure could be the default activity when an individual is not working. And so we don't say anything about the quality of this leisure time. And finally, we see that the substitution of paid work for leisure and sleeping is largest among those that have both definitions of disability. And in some cases, it's not statistically significant for those that have just one type of disability. So this really highlights the fact that different definitions of disability capture different populations of individuals with disabilities. And it's important to capture this type of diversity within individuals with disability when looking at time use and other measures of well-being. And that concludes our findings for you today. Thank you very much. And here is my contact information if you'd like to get in touch later. Thank you.
I'd like to thank all of you for coming, and for those of you on the phone. And also, I would like to acknowledge funding, as Dave mentioned, from NIDER's Employment Policy, ROTC. This is joint work with Gina Livermore, although notice she had me present and not her, so hopefully I'll do a good job. In any case, today I'll be talking about gaps in timely access to health care among workers with disabilities. And really, we were interested in whether or not the ACA would change the landscape. Individuals with disabilities often have very complex conditions that they have to manage, and health insurance is very critical for that group. And so we really wanted to see how the ACA may change what we're observing given the current situation prior to the implementation of the reforms. It's well documented that people with disabilities face more difficulties accessing health care than people without disabilities. Lisa Izoni has done a lot of work in this area. There is a group out of UNH that has done work more recently looking at this. But there's relatively little information on how employed people with disabilities fare. There's been a lot of emphasis in recent decades in getting people with disabilities back to work, yet there may be unique challenges faced by this population. They may be healthier than their non-working peers, which may be why they're able to engage in employment. They may have different health insurance options. Prior to the ACA, health insurance was primarily through the employer context, and so the people who are working may face a different set of choices. But they also may have a lot of difficulty managing health care while working. There's a lot of work that's been done out of the University of Massachusetts looking at the Massachusetts health reform, and a lot of the work that they've done have talked to workers with disabilities, and they've documented that for those people who are working, it is very difficult, especially if you're trying to work full-time, to get to a doctor during office hours, or to just manage the complexity of your conditions. And as Priyanka just showed, they do spend more time in health-related activities. And so the purpose of our study was to go beyond what's been done in the literature so far, is to look at disparities in access to care for employed people with disabilities relative to their non-disabled counterparts. And I want to be clear here, we're using the word disparities relatively loosely. I know there is a very technical definition of disparity. We are trying to look at differences in access to care and the extent to which policy reforms may make a difference in this instance. We used data from the NCHS's National Health Interview Survey. We used a version of this data set developed by the University of Minnesota, and I want to give them credit because they make it very easy to conduct analysis using this. They've created cross-wave consistent measures of a lot of the things in NHIS, which makes it really valuable for researchers new to the data. We pooled data from 2006 to 2010 because this was primarily prior to the implementation of the ACA reforms. In late 2010, there was a little bit of activity starting, but by and large, this is a time period that was pre-ACA. And we really intended for our work to be a benchmark that could be used to track the access to care among people with disabilities in the future as the ACA reforms are implemented. For employment, we looked at a group of people who were between 18 to 64, so working age, and who reported working for pay in the last 1 to 2 weeks. The NHIS does contain a measure of employment that looks over the last year, but because we were interested in characteristics of one's job, and it needed to be their current job, we focused on a measure that was 1 to 2 weeks in the past. And I should point out that had we used this larger one-year measure, employment rates would have been about 10% higher than what we found. For disability, unfortunately, we weren't able to look at both types of disability measures like Priyanka was, but it was the measure that looks at a self-reported health condition that limits the type of activity that one can do. And because we're looking at a group that is employed, this is a relatively small group of people in the sample. So it's 3.5% overall. Similar to statistics from other data sets, we found that far fewer people with a disability were employed. In ours, it was 24% of people who had a disability were employed relative to 77% of those without a disability. And the 3.5% really shows why we had to pool data across years. The NHIS is a very large data set, but by the time you're trying to focus in on a group of people with disabilities who are employed, there really just isn't a large mass, so we pooled data across years to make sure that we had statistically significant results. We looked at several measures of timely access to care. The first, we put in a bucket of cost-related access difficulties, and within this, there are 2 different measures. The first is whether or not people reported that they had to delay their care in the past year due to cost. And 11% of the overall sample, both disabilities and not, reported having to delay care at least once in the past year. About 8% of the sample reported that they needed medical care in the past year that they could not afford. And while these measures seem like they're very similar, there actually was a fair amount of overlap between them, but there was a significant group of people who reported that they delayed care due to cost, but did not report the second measure. And so these are overlapping but not identical measures of cost-related access issues. And we also looked at the composite measure of any one of 5, what we're calling structural access difficulties. So really, difficulties accessing care for reasons not related to cost. And this includes any one of the following: lacking transportation, not being able to get an appointment soon enough, having office hours that were not convenient, not being able to get through to the doctor's office by phone, or a wait at the doctor's office that was simply too long. And among our sample, 11% overall reported any of these difficulties, at least one of them. The most commonly reported by 20% was not being able to get an appointment soon enough, and also that the wait at the doctor's appointment was too long. Each of those groups alone represented 20%. And you can see for people who are working why some of these may be particularly salient. Having office hours that weren't convenient or having a long wait if you're taking time away from work. These may be things that are very important for workers with disabilities as well as workers in general. Now, what's really interesting is that these measures differed quite a bit by whether or not people had a disability. And this mirrors a lot of the work that's been done in this area to date. Relative to people without disabilities, employed individuals with disabilities were 3 times more likely to report that they had to delay care due to cost in the past year. And about 3 times as likely, 3.5 times as likely to report that they needed care that they couldn't afford. Structural access difficulties in the past year were twice as likely among people with disabilities relative to their non-disabled counterparts. And so you really see that on the unadjusted measures, there are really big differences in the likelihood of having difficulty accessing care. Now, Priyanka highlighted in her analysis, there are reasons to think that some of the demographic differences between workers with and without disabilities may be driving some of this. And I just want to highlight a few of the differences that we observed in our population. Relative to individuals without disabilities, workers with disabilities tended to be older, they were less educated, they were less likely to be married, and nearly twice as likely to live alone, and are twice as likely to be in poverty. And so you can see why some of these characteristics would be associated with having difficulties accessing care, either because of cost. For example, living in poverty, having less education, often tend to work in jobs that don't have health insurance, and also encountering structural access difficulties. For example, if you're living alone and you require transportation, you may not be able to get to a doctor's appointment the way someone who is living with a spouse or someone else would be able to. We are also interested in the extent to which job characteristics could explain some of these differences. We are looking at workers with disabilities, and so we were wondering whether or not the insurance coverage that these individuals had would explain some of the difference, both in terms of having coverage at all and the quality of coverage that they had. And we found that relative to people without disabilities, workers with disabilities were less likely to work full-time, slightly more likely to be paid hourly, less likely to have paid sick days, which is often correlated with the offer of health insurance from one's employer. They're more likely to work in blue-collar jobs and less likely to be in management positions. And because the ACA focuses on firm size for the employer mandate, we are interested in whether or not workers with disabilities tended to work in firms of different size than workers without disabilities. And while there was some shifting of workers with disabilities to smaller firms, it really wasn't as large of a difference as we expected. It was on the order of about 3 percentage points. One thing that really struck us was that while the rates of uninsurance among workers with disabilities was about the same as those without disabilities, there were really large differences in the source of coverage. So as you see on the bottom row here, 20% of those with a disability were uninsured relative to 17.5% of those without a disability. And so while there is more uninsurance among those with a disability, it's not nearly as striking as you might expect among individuals overall who aren't employed. But what you really see here is there's a very big compositional difference in where the source of coverage is coming from. Workers with disabilities are 15 percentage points less likely to have coverage from their employer, perhaps because they're working part-time and in hourly jobs, but they make up this lack of coverage from other sources, primarily through Medicaid. Medicaid coverage among this group is 10.5%, or 5 times higher. It's 10.5% among the whole group. And other public coverage, which includes Medicare benefits, VA coverage, and other public sources, is about 4 times higher. So while there really isn't a difference in insurance, there is a large difference in where the coverage is coming from, and this may play a role as the ACA is implemented from where people are going to get coverage going forward. So to account for these differences that I've described, we used a logistic regression model to generate the likelihood of experiencing access difficulties, holding constant the differences between these two groups. And what I'm going to show here are the means that we found once we assumed that individuals with and without disabilities had the same characteristics. So we're really trying to isolate the effect of having a disability. And as I mentioned, we control for all the features I've showed you so far: demographics, income relative to the federal poverty line, insurance status, and job characteristics. And so to focus first, these are the numbers that I showed you previously, that workers with a disability have 32% of them have reported delaying care due to cost in the past year, relative to 10% without a disability. The next set of bars I'm going to show you is when we've accounted for the demographic and job characteristic differences between these groups. And we see that the gap is narrowed in a meaningful way. It went from about 20 percentage points down to about 15 percentage points. But a significant gap remains. So even accounting for differences in demographics between these two groups, we see that those with disabilities still have a significantly more difficult time accessing care for cost reasons. Similar findings if we look at needing care but not being able to afford it. Again, without making any adjustments for differences between the two groups, it's about an 18% gap, 8 percentage point gap, and afterwards it's a 13 percentage point gap. But it is, again, 13 percentage point gap when those without disabilities only have a rate of reporting needing care that they couldn't afford at 5%. So this is a very meaningful gap, even accounting for differences. Interestingly, when we made the similar adjustments, there was very little movement in the extent to which workers with disabilities experienced a structural access issue. I don't really have a good sense of why that would be, but we were stricken by the fact that this really didn't change the gap at all for this measure where it did for cost. The one thing I haven't mentioned is it probably goes without saying in this room that workers with disabilities have significantly worse health status than their non-disabled peers. They are substantially less likely to report being in excellent health, only 27% of those with a disability relative to 72% of those without a disability, more likely to report being in good and fair health, and they're 5 times more likely to have spent at least 5 days in bed in the past year. And so this is a group that is much less healthy than their non-disabled peers. And so you may think that the reason that we've observed some of these access difficulties is simply because they've accessed the system more in the past year. So if you're significantly less healthy and you've been to the doctor 10 times more in the last year, it's much more likely that at least once you've had a hard time getting through when you call the doctor, or much more likely that you've had a hard time affording health care. At the same time, health care affects one's health, and so we didn't want to initially include this in our model. And so what we did is, after all of the things that we had controlled for so far, we then thought it would be illustrative to consider how much of the remaining gap we could be explained if we included health status in our model, as well as all of the other differences that we observed. So this bar shows the adjusted gap from before, where we've adjusted for all the differences between the group. And you can see that the gap was 16 percentage points without controlling for health when it was looking at delaying care due to cost. The gap was cut in half once we accounted for health status. And so this is a really meaningful effect. So this does say that some of the difference is being driven by likely seeing a doctor more during the past year. But what is striking here is that access difficulties are still twice as high among individuals with disabilities. So even after controlling for a host of factors, including health status, we still see that workers with disabilities have a significantly higher chance of having an access difficulty. Basically the same pattern when we look at needing care that they could not afford. The gap was reduced from 11% down to 4% percentage points, but this still remains nearly twice as high among workers with disabilities. Structural access issues remain 50% higher after we account for all of the differences. And so we see here that we're able to explain a lot of the gaps in accessing care from when we didn't account for any of the differences between the two groups. But even after controlling for health status, and it really is an open question whether or not you think health status should be accounted for, and because that's what's driving the need for care, workers with disabilities have a significantly more difficult time accessing care during the course of a year than workers without. And so I started by saying that really we were interested in where the ACA make a difference here. The ACA likely won't affect structural access barriers. It's not going to provide transportation. It's not going to change waits at the doctor's office. If anything, I think preliminary evidence is suggesting everyone may have a longer wait. But it may meaningfully reduce cost-based access difficulties, and especially for workers with disabilities. And so I wanted to talk a little bit about why that might be and where we might see significant improvements. So I think there are certain provisions in the ACA that are going to benefit all workers. The first that's already been enacted is the dependent coverage through age 26. The employer mandate, to the extent it's implemented, will also likely benefit workers both with and without disabilities. And I have the removal of pre-existing condition limits affecting all workers, although I think it will disproportionately affect workers with disabilities. I put it here because our measure of disability here is work limitation, and I think there are a significant number of people who may not report having a work limitation in this survey, but may have a pre-existing condition that would have restricted their access to health care. And so I think it's disproportionately likely to affect workers with disabilities, but it will benefit all workers. But I think there are other provisions that are substantially going to change the composition of health insurance coverage for workers with disabilities. And to the extent that that difference is going to allow workers with disabilities more access to care, we may see meaningful improvements. The first is Medicaid expansions, although, as we know, this isn't happening in every state. And if we assess this in the future, we'd want to look at state-level estimates. To the extent that Medicaid offers individuals a greater opportunity to get the kind of care that they need, and that's particularly true for workers with disabilities, this may have meaningful benefit. The availability of exchange-based coverage, this could be particularly salient for workers with disabilities, especially those with mental health conditions who often go in and out of employment, and so to the extent that the exchange-based coverage would allow them continuity of care while they tried to go back to work or had to leave for treatment. And also income-based subsidies. I mentioned earlier that workers with disabilities are twice as likely to be in poverty. The income-based subsidies will therefore disproportionately benefit this group. And so both increasing coverage for everyone and changing the mix of coverage for workers with disabilities, I think there may be reason to think that the situation will increase, but it remains an unanswered question, which is why we wanted to have our study as a benchmark so that we could look going forward. I will leave you with my contact information as well. Thanks.
Hello, I'm going to talk about poverty among SSDI beneficiaries, and I apologize to those of you who saw this presentation last month at the Disability Research Consortium conference, and that I know the grad student that Dave was referring to was one of those people. And this work was supported by the Social Security Administration under the Disability Research Consortium. So what was the motivation behind this? Well, this was one of a series of 3 papers we were trying to profile certain subgroups of Social Security beneficiaries or look at particular issues and show data from the National Beneficiary Survey, which is a survey of the it's a nationally representative survey of beneficiaries that SSA has sponsored 4 rounds of since 2004. And we chose to look at SSDI-only beneficiaries in poverty because we know from that data and other data that a very large share of DI-only beneficiaries live in poor households, 28%, which is about 3 times the rate of poverty that we see among the general working age population. And the fact that they're SSDI only means they don't also qualify for SSI, Supplemental Security Income, which is the means tested program designed to support either retirement or when your disability insurance benefits are too low. So these people fall through a little crack where their benefits on DI aren't high enough to get them out of poverty, but they aren't low enough to qualify them for this other support, income support. So we're interested in looking at the characteristics of this group and some of the reasons that they might be poor despite the support of the Social Security disability insurance. And they're also of interest because they may be an important target group for employment supports. They have a work history by virtue of being DI only eligible. They're clearly their DI benefits must be low. That's why they're in poverty. And so the opportunity cost of working, what they have to give up in terms of their benefits, is also low, so they might be more likely to want to go to work and lose their benefits. And earnings might improve their economic well-being above where they are simply relying on their Social Security benefits. So, like I said, we use the National Beneficiary Survey. We pooled 4 rounds so that we'd get enough people, DI-only beneficiaries, to look at. And we grouped people based on their household income, and household income, not just their own personal income, relative to the federal poverty level. And I'm only going to focus on the 2 groups shown in red on the screen, those who fall under 100% of the federal poverty level, poor individuals, or as we refer to them, and household income 300 or more in the federal poverty level. That's actually the highest category that's available on the public use National Beneficiary Survey. And we refer to those as higher income DI beneficiaries in higher income households. So what are some of the predictors of poverty that we found in looking at the characteristics that are available in the National Beneficiary Survey, at least some of them? So we ran regression models holding other characteristics constants to see what were the important factors. And you're more likely to be poor if you're younger, if you're unmarried, non-white, you have low level of education, if you have children under age 18 in the household, and if you've been on the disability rolls, either SSI or SSDI, for 10 or more years. And the two shown in red, being unmarried and lower levels of education, those were the strongest predictors. Those had the biggest impact on your likelihood of being in poverty relative to other factors that we threw into the model. And you were significantly less likely to be poor if you obviously did not have those other traits that I just mentioned, and if you had a sensory condition, which included hearing impairments and blindness, and if you were working at the time they were interviewed for the survey, you were less likely to be poor, all else constant. So this just demonstrates the differential that some of those characteristics have in your likelihood of poverty. So holding everything else constant at the means for the whole sample, if we just turn on and off having less than a high school education, if you don't have a high school education, you have 36% probability of being in poverty, all else constant, relative to an 18% likelihood for someone who has education beyond high school. So you're twice as likely if you don't have a high school education. You're more than twice as likely if you're unmarried relative to a married person, 37% versus 14%. And you're a little bit more likely, about 50% more likely if you have children in the household, 34% versus 22%. And working also reduces it by a third to 50%. If you're not employed, all else constant, you have a 25% chance of being in poverty versus 18%. So in looking at the employment activity and their work goals of folks, comparing the dark blue is the individuals in poor households and the light blue are beneficiaries in higher income households, the survey asked, do your personal goals include work or moving up in a job, or do you see yourself working in the next 5 years? And a much greater share of individual beneficiaries in poor households, 41%, said that yes, their goals include work or they see themselves working, compared to 30% of beneficiaries in higher income households. And those in the lower income households were also, in poor households, were much more likely to have ever used employment services. And that makes sense given they have lower levels of education, their benefits are low, implying they probably had lower skilled jobs while they were in the workforce. So they were much more likely than those in higher income households to ever use employment services. But they didn't differ significantly in recent use. So the year before we interviewed them, we about services in the year before when we interviewed them, and they were equally likely to have used employment-related services. So among those who were not working and said that they wanted to work, so that on that previous slide, the 41% who said they were interested in work but were not, they were asked, reasons why they weren't working. So what were some of the employment barriers? And there were some differences between poor and higher income beneficiaries. Poor beneficiaries were much more likely to say workplaces were inaccessible, 28 versus 19%. They were also more likely to say they couldn't find a job for which they're qualified, and they also were much more likely to say that they lacked reliable transportation to and from work. So actually looking at how many were working and had ever worked for pay, the first bars show having ever worked for pay. And those in poor households were much less likely, 91% versus 97%, to have ever worked for pay. And you might be wondering, well, this is DI-only individuals that you have to have a work history to qualify. Well, you can also qualify as a disabled adult child or as a disabled widow or widower based on a parent or spouse's earnings history. So evidently, even though we can't identify those people in the data that we had here, more of those types of individuals, widows and disabled adult children, are in the poor category than are in the higher income category. In terms of working in the prior calendar year or being employed at interview, no differences between the two groups. Statistically, that is. There are small differences, but not statistically significant. So looking at their sources of public assistance and other benefits, as you might expect, those in poor households were more likely to participate in means-tested program like Medicaid, 50%. And these, keep in mind, these are DI-only individuals. They have Medicare already, and they would only qualify for Medicaid if their health conditions spent them down into those categories. They were in a buy-in program, or their income and assets were lower enough to get into some state category for Medicaid. So a lot of them had income low enough to do that, 50%. They were highly likely to be using food stamps, 30%, and to receive housing, energy, and other types of food assistance. And they were much less likely to have higher SSA benefits, $1,500 or more a month, was the category shown here. 42% of those in higher income households had higher benefits like that. Only 12% of those in the poor households. They were also much less likely to have income from private sources such as pensions, private disability insurance, workers' comp, or unemployment insurance. So again, these last two columns point out the low opportunity cost of working. They're not going to be giving up much in terms of private disability or Social Security benefits if they do go to work and their earnings make them lose those benefits. So to summarize, poor DI-only beneficiaries have many of the same traits that are associated with poverty in the general population. They're younger, they're unmarried, they have children, they have low levels of education, but they also have this added challenge of a significant limiting health condition. And SSDI is an important source of income for them, but it's insufficient to keep many on the program out of poverty. And you know, it was originally structured as an early retirement program within, you know, thinking that people have a whole rich work history and that this is a way to allow them out early, and then it was expanded over time. And now the people on the rolls are very different from what was envisioned. We have people coming on at younger ages, so their earnings history is going to be a lot lower. Or we might have people that for a long, long time had very low levels of earnings. So if you have early onset or lifetime of low earnings, you're going to have low DI benefits. And to really affect the poverty rate for this group, at least through the DI program, you'd really have to raise the minimum benefit. It's difficult to change in work I did 20 years ago, I looked at changing the formula for benefits based on lifetime earnings, and it's really insensitive to tweaking. You really have to raise the minimum benefit that people could get, or raise the benefit that they might, or eligibility they might get a bump through SSI. And that costs a lot to do that because there's a lot of people in this category, and it's not really a politically viable option right now when they're trying to address trust fund deficits. Another reason for not wanting to do that might be that when you think about how the value of SSDI relative to the wages they were earning before they left the labor market, what's referred to as a wage replacement rates, are already very high at those lower levels of benefits given the way they calculate it. It's the benefit calculation favors low wage earners anyway, and to make it more favorable would probably not be very desirable because people would think there'd be effects of drawing people out of the labor force and into DI. So employment might be an option and may help some improve their economic well-being. As I said before, most have a work history, and as we saw from the numbers, most or many have a strong interest in employment, or say they do. And because they're young, investments in improving their work prospects might substantially offset long-term receipt of public assistance. And we saw they're 50% are on Medicaid. That's a lot of money. The food stamps probably not that much, and the DI benefits probably not that much. But if you can just get them off of Medicaid, you're probably going to have big savings. But as we also saw, there were some significant barriers that would need to be addressed before many could be successful. And the low levels of education and training is probably number one. Childcare, because a good chunk of these folks actually have children at home, so might face some of the same issues as the TANF population. Transportation, workplace accommodations, and probably a big one is disincentives associated with the DI cash cliff. Although these people, because their benefits are low, it may not quite be as bad as individuals that are receiving higher levels of DI. All right, thank you.
Thank you, Gina. Before I jump Chida, let me just remind the webinar audience that we love to hear questions from you. So this would be a good time to submit your questions via the Q&A panel on the screen, and we'll direct them to one or more of our speakers during the Q&A session after John finishes his remarks. Remember to please indicate your name and institutional affiliation. John?
Thank you, David, and thanks to Mathematica for continuing to host this series of very important policy presentations addressing some very difficult issues, in many cases doing it with NIDER's money. And we have a long relationship with Mathematica and expect that to continue. It's great to see you folks doing good work, and again, hope that will continue into the future. Thanks to Priyanka and Jody and Gina, too, for very enlightening presentations. I'd also like to acknowledge my former colleagues back in Minnesota, several of which I know who are watching the webinar. This gives me an opportunity not just to say hi, but to mock them. So we are, as David has mentioned already, in the throes of a major transition at NIDER, moving from education to the Department of Health and Human Services. I'd like to spend a few minutes at the end of my comments to chat about that and let you know where we're at in that process. But first, to react to what we've heard today, which again is a very rich and deep set of data, and I think our presenters have done disabilities often lead very complicated lives. My previous life, working to change state policy back in Minnesota, we used to talk often to policymakers about the four-legged stool that was required for folks with disabilities to live successfully in the community. And the components of that stool are employment, health, services, and I use that term very broadly. I intentionally did not say health care, but health services that would include social supports that are not necessarily medical in nature, but employment, health, housing, and transportation. And what we talked about today were three of those four components and the challenges that individuals face when any one of those key components is not working well. We know that those programs are not funded in concert at either a federal, state, or local level. The policy-making decisions absent the money are also not done in any coordinated fashion. So we've seen from the results what the implications are of what we see when any one of those legs is not working properly. So for me, the major takeaways from what we've heard, the employment picture is bleak. That's not a surprise. That's something that we know historically, and folks have said that. I do think there is promise that the ACA holds. And we can talk a little bit more about that later. The major income support program, SSDI, that Gina mentioned, is necessary but insufficient for a very large portion of the population. Social determinants of health matter, and in this case, probably transportation, which came up in both Gina and Jody's presentation in terms of a substantial challenge. Gina's case, there were also accessibility challenges related to the built environment that limited access to employment, but these social determinants have a profound effect on health and economic status as well. Having a disability in many ways is work, as we heard in Priyanka's presentation. I was surprised that the number, especially related to health-related activities, wasn't larger than it was, but 40 to 50 minutes per week remains a substantial amount of time. And having a disability isn't cheap either. Decisions are being made by many to defer care due to cost, even with co-payments, strict co-payments in place, especially relative to the Medicaid population, where they were overrepresented relative to their able-bodied peers in at least one of the presentations that we heard today. So a little bit more about each of the presentations, and Priyanka's in particular. I've long been fascinated by the concept of efficiency and disability, or more appropriately, the inefficiency of disability, where systems and supports don't tend to work in concert with what people need. And in that health-related activity variable, a question I wanted to ask is, did that include the time that was also spent navigating the systems necessary in order to get to their health-related activities? So things like transportation in particular. If you go to NRH on any particular day, and unfortunately I've been there more than I would desire in the last couple of months, you see folks in their lobby who are there for a 1 p.m. appointment, but because the paratransit ride was only able to pick them up at 10 a.m., that was an all-day affair for them, which is challenging. It's a great lesson for lawmakers, too, when you're trying to lobby for improved systems. But managing health, certainly there are appointments that people are attending, but there are all the associated systems around managing that health that are often problematic for people. So we know that both men and women with disabilities sleep more and work less than their able-bodied peers, as we heard. They spend more time on leisure activities, and as Priyanka said, we don't know anything about the quality of those leisure activities, and they might be a default for not working, but I'm also very interested in what the quality of those leisure activities might be and what the associated challenges to accessing the supports and systems that would allow for high-quality leisure activities, as I just mentioned, what that might be and what they could be. Are they desired activities? Are they things that folks are doing independently, or are they happening in a social context with others, social participation? Strong goal of everything that we fund and do at NIDR and my agency. Are there additional limiting structural barriers, such as transportation, that are affecting their leisure choices, hopefully not legal choices? And again, I think we need more studies like this to understand not just what choices people with disabilities are making, but how their choices may be limited due to barriers in accessing needed supports. Jody's presentation on gaps in timely access to care. Bad news on the employment front again, with just 24% of the sample employed versus 77% of the able-bodied peers. The descriptives were very similar across the three studies in terms of both in impoverishment as well as individuals less likely to be married or have another individual in the household. I think there are also associated challenges there with folks who don't have a support person in place to assist them in accessing care necessarily, as you would if you're living in a multi-member household, or assistance in navigating the transportation difficulties, which she had as one of her structural barriers to care. Not surprising that the Medicaid usage here was 5 times what it was in the able-bodied population, and in some ways that's good news, because Medicaid represents a benefit set and support services that no commercial plan in America will cover, things like personal attendant services that are only maintenance in nature but not skilled care. And for folks with severe disabilities, that's a significant issue. No surprise that we see worse health status in this population, and of course the implications of that, in addition to what Jody has mentioned, an increased burden of illness, missed work, cost both individually to the individual in terms of economic consequences, but also quality of life consequences when we're seeing those additional days in bed, but also increased healthcare expenditures and system costs as well to the overall system. And as we know from previous research, folks with disabilities have a thinner margin of health, meaning the line between sickness and health is thinner than those of our able-bodied peers, and the slope of the line is relatively steep once that decline starts to happen. So certainly don't want to see population. So the promise of the Affordable Care Act, again, access to Medicaid, where individuals now, because of the expansion, although it may be not uniformly applied across states, being able to access through the income door rather than the disability determination door, which often means there isn't the punitive economic consequences that require with the level of impoverishment. Not that those income levels are high necessarily, but they are higher than they used to be in some states. What are these exchange products going to look like, and what are the take-up rates going to be? So I think it's critical that we have a baseline here pre-Affordable Care Act. What is that change in take-up going to be? We know that advocates fought hard at the policy level for the inclusion of critical disability-related benefits in those benefit sets. Are they going to be deep enough for individuals to access in a meaningful way? Is the commercial market going to be viable, let alone affordable, for individuals with complex conditions and disabilities? So I look forward to Jody's possibly NIDA-funded work on a post-Affordable Care Act analysis of some of these same hard questions, but necessary questions that need answering. And finally, Gina's presentation on SSDI. Again, in the barriers to work section, we saw transportation again, those social determinants being critical, accessibility challenges being significant when it comes to the built environment, no surprise to folks with disabilities, in addition to the other limiting factor that they just can't find work. We saw higher take-up rates of both Medicaid and food stamps in this population as well. And nothing's going to change in this area until we get significant policy change, and the primary barrier there, as Gina has said, is political. A plug for the next forum and the benefit offset national demo project that is going to be the focus of the February forum. We need more programs like that to provide an on-ramp to employment for individuals with disabilities, to avoid that cash cliff. Even though the folks in the study that Gina talked about were lower income earners relative to some others in the program, and that may not be as limiting a factor for that cash cliff, but it does remain a significant challenge for many individuals on that program. I think we're all aware of the election results that happened in November. I heard a rather sobering presentation yesterday, as many other folks in the room did, from the Center on Budget and Policy Priorities. The outlook is not necessarily good for Social Security, but it is something that's going to need to be addressed, and that may happen in budget negotiations that would occur as soon as next summer. So more to come, and I look forward to hearing from the more about the benefit offset national demo project in the near future at the next policy conversation. So at NIDR, these are also questions that we are asking of ourselves, and as we're looking to funding projects in fiscal year 15 and beyond, and you should look for those on our website within the next couple of weeks. And while I can't speak to the specific nature of those requests, we are asking questions about the Affordable Care Act. What are the interactions between the Affordable Care Act and SSDI, for example? What are the opportunities there? What are the effects of these new policies on employment-related decision-making for individuals with disabilities? What are the rates and the quality of the employment that we're seeing as a result of those policy changes? Medicaid expansion, exactly what is happening there? What choices are individuals with disabilities? Are they accessing the Medicaid program in ways that they weren't before, or getting access to buy-in programs, or learning more about Medicaid eligibility that otherwise not available to them? We're also in this difficult policy environment asking other questions about health policy and specifically non-medical services or long-term social supports. And there's a real challenge there when it comes to answering the value question, when it comes to seeking additional funding or sustained funding at either the state or federal level for these critical services for this population. In all of the health reform conversations, there's been a tremendous amount of work related to quality measures, disability, and the services that folks with disabilities need and access, particularly through the waiver programs, have not really been a part of that conversation. I think that's something I'm looking forward to working on in our new home at the Administration on Community Living. This is a priority area for them. It's something that I have a very strong interest in. As you may know, they have a 2-year project that they've just undertaken with the National Quality Forum to look at the parallel. And unfortunately, in Washington, these conversations are often parallel related to the establishment of quality measures and where can we develop some synthesis and really make some forward progress in this area as a way to defend the services that exist today and really look at true outcomes, not process measures, for the effects that these are having on disabilities. So I think I've used most of my time relative to our merger. I think I will just say things are going very well. Although we are working as quickly as we can, we are also working as responsibly as we can to make sure that our multiple stakeholders, especially our grantees, are not adversely affected by the transfer from education to HHS. Are philosophically aligned with everything that they do there. Our roots are in the Rehabilitation Act and the assumptions that that makes about inclusion and social participation for individuals with disabilities, and look forward to coming before you again at some point in the future after our merger is completed successfully to talk about the good work we're doing there. Thank you.
Thank you, John. Very interesting remarks. We're now going to open it up to Q&A, and before I do that, let me just say that if people have questions for John about the transition to HHS and his role in that, I think that would be fair game, unless you don't want to answer them. But
sure,
you can always say no. But I know there are people that are probably interested, and I like to give people a chance to ask if they'd like. So we're going to go ahead now and with the questions, and I think we'll start with one from the webinar audience, and then we'll look for somebody in our in-person audience. And so, Crystal, do you have one lined up for us?
Sure. We have a couple questions from the webinar audience. The first is from Tom Wilson, and he asks, what would be the impact of raising the minimum wage significantly for disabled workers? I think this is specifically aimed at Gina in her presentation.
That's a complicated question. Well, as you might have seen on the slide, not a whole lot are actually working on the DI program, and there's a lot of reasons they're not working, and garnering low wages in the labor market might be one of them, so it might induce more to actually work. But on the other hand, there's a lot of controversy, I think, about that too, because they're the 14C, the sub-minimum wage certificate population. Some people are worried in mandating a minimum wage and not allowing those individuals to work below minimum wage would eliminate opportunities they have to, even though they're not working a ton, to engage in productive activities and not be sitting at home or in rehabilitation. So I'll say I don't know, and I think we don't really know what that would do for the general population of low-income workers. You know, economists will give you their ideas about that, but in terms of would it induce some people with disabilities work? Sure, I'm sure it would. So.
Okay. Do we have one in the room? Yes. Bonnie, Alex is going to bring a mic up for you. Oh, we got Frank beat you to it.
So,
get you next time.
just one quick question for Priyanka.
Frank, could you identify yourself and institution?
Sure. My name is Frank Martin. I'm a researcher at Mathematica. My question for Priyanka pertains to the definition of personal care. Can you talk a little bit more about how that was defined? And I think for many people with disabilities, personal care actually includes health-related issues, and whether or not health care then would be underestimated in your models, if that's the case.
Yeah, so personal care includes things like brushing your hair, bathing, anything that you do to get ready, whereas health-related activities is targeted more at whether you're going to the doctor, you're taking medication, things that are really targeted to your health condition. But I think it is a fair point that personal care, one of our original ideas is that personal care, so including things like getting ready and brushing your teeth, things like that, depending on the disability, could actually take longer. And that's why we included it as a category of looking at, well, do individuals with disabilities spend more time on this? But we do ultimately create this distinction between things that are targeted towards actually addressing your health needs versus things that you do every day to get ready for the day. So.
Thank you. Crystal, do you have another one?
We have another question from Carla Paradine. She asks, she'd like to hear more about what trainings are needed to help transition people, especially students, to first-time jobs, and what current VR counselors are doing to help them, and if there's any particular skills that would really help. And I think this kind of goes to those economic and job questions.
These are difficult questions. And they're not,
Yeah, what the heck?
We're supposed to screen those
they're
out.
sort of on topic and not on topic. But if somebody wants to take it on, you certainly may. But if you'd rather not, that's fine as well.
Well, from a NIDR perspective, I would just strongly encourage the participant to go to our information clearinghouse, which is NARIC, N-A-R-I-C. Just Google that, and you'll find a host of research projects that we've funded on transition issues, specific interventions, both in a VR context and a non-VR context. There's a lot of work that's out there, but it's a very complicated question depending on what subpopulations within the disability population you're looking at, as well as whether you're talking about the VR system or a non-VR system.
Yeah, and I think the other stuff that Mathematica work has found is having work experiences while they're still in school. And, that's probably out of the purview from the VR perspective. But the younger you start and the earlier the expectations are for employment and the earlier they have those kinds of experiences, the more successful people have been, or at least that's what the studies have shown.
Might be worth mentioning that on Tuesday there was a meeting hosted by the American Enterprise Institute in Brookings. It was Tuesday, right? On this topic, youth transition and policy in that area, and it featured Tom Fraker spoke about the youth transition demonstration, which we've been evaluating, and we're finishing up the reports on that now. I know some people in here are working on that. Arif, do you know what the schedule is for getting the reports out?
The report is actually now public. It's available on SSA's website.
Okay, that's great. And maybe people couldn't hear Arif. He said the final report for youth transition demonstration is now public, and it's available on the Social Security Administration's website. Bonnie, you've been very patient. Maybe we can. Alex, you can bring the mic up here. Oh, you get.
Okay.
I told Bonnie she'd be
Okay,
next. You
that's
got
fine.
away, sorry.
Thank you. This is a question for Priyanka, and I can't remember if I've asked you this before, so I'm going to ask it again. Have you ever thought about segmenting the population into individuals with disabilities who work hopefully full-time or more than 30 hours versus those who don't? Because I bet that you would see that the work time, the time people spending with work would significantly increase, and the time that people spend in recreation activities would decrease below that of what non-disabled people spend because of the issues around getting other things done, getting to work, accomplishing your work, etc. And I'm wondering if the sample sizes would allow that kind of analysis.
Yeah, I think that's a great suggestion, and it's not something that we have done yet, but I think you're exactly right that we would expect the time use to be very different for individuals who are working versus those who aren't. And I would have to look back at the sample sizes to see if they're large enough. I mean, 25% of the sample is working. And so this is something we should pursue. So this particular paper didn't focus on that, but I think it's a great suggestion for another paper to look at.
Great. John, did you hear that?
The new grant method here. So.
And actually, just to build on that, I also think, John, your suggestion of looking at leisure and really understanding it better is an interesting one. There is a paper by Ricardo Pagan that looks at leisure using a different data set, a different sample of people, but looks at whether the time spent on leisure activities is more focused on active leisure versus like non-active leisure for individuals with disability and without. And so he has some really interesting findings, and I think it would be worthwhile to look more deeply into leisure time to understand what type of leisure, as you suggest. So, yeah. So thank you both for those suggestions.
Okay. Crystal, do you have another? No? Okay. Back, way in the back.
Dave Oxter, Research Institute for Independent Living, and this question is about the quality of leisure activity. If I got it right now, okay. Leisure activity can either be constructive or destructive. I mean, you have leisure activity that involves substance abuse, sedentary, and a lot of other characteristics. And on the other hand, it can be very productive to society and the individual. And so my question is, do you have any data on the leisure lifestyles of the comparisons between the groups? And then the other thing is the area of social determinants of health was raised, and what is the impact of social determinants of health on the healthy lifestyles of individuals?
Yeah, I think that's a very important point, that this category of leisure that we're looking at is very diverse. As I mentioned, we started with 400 plus activity codes, and we define leisure. We use this technical definition, which is any activity that provides direct utility to the person. And this includes many different things. It includes watching TV. It includes reading. It also includes, talking to your family, talking to your friends, or things like that. And so I think it would be interesting, in addition to the work that other people have started in looking at, active versus non-active, diving more into the subsets of leisure activity, as you suggest, constructive time versus less constructive time. And it's something we could do because we do have these very specific activity codes within this category of leisure. So I definitely agree that this is an area to be explored further.
David? No, she's no.
Jody, this is a question for you on your work. It was interesting to see that the lack of difference in overall uninsurance rates between the two groups, but the composition of the plans differed very substantially between those with and without disabilities. And in particular, those with disabilities were much more likely to be on plans like Medicaid. And so my question to you is, how much are the access to care issues potentially driven by differences in the plan? And is there any way to assess that? I know you tried to control for that with health, but I'm wondering if there's any other thoughts that you have on that, particularly given your policy conclusions with the ACA.
Yeah, we did adjust. We looked at what would happen if we adjusted for everything other than insurance status. And you're putting me on the spot for something we did a year and a half ago, but I believe what we saw is that those with Medicaid reported fewer access difficulties than those who had employer plans, and that I think is consistent with some of the work that has come out of Massachusetts. I mean, as John mentioned, they have a different set of benefits that are covered, particularly personal care, and that's really important for this group. And so what we found was that the gaps were about the same if you held constant insurance status, so disabled and not, workers with disabilities and not, but across insurance categories, obviously the uninsured were the most likely to report access difficulties, followed by those with Medicaid, followed by those with employer-sponsored care. So.
Any others? Yes. Right here, Patrick.
Mm-hmm.
Yeah.
So Gina, this question is for you.
Please, Patsy, identify yourself.
Oh, sure.
Your former employer.
Yeah. So my name is Patsy Lloyd, and I work at the National Center for Health Statistics, but formerly at Mathematica. So my question is for you, Gina. You mentioned that the SSDI, so the respondents in the NBS survey, that they were SSDI only, so that they were eligible for Medicare, but there's this 2-year waiting period. So I know that you also mentioned that there were some that were in SSDI for 10 plus years. So your sample, were there many that were in there for only 2 years or less than 2 years that maybe you're not under Medicare?
Not that many in the NBS. It's probably 5% or less. So that doesn't account for much of that 50% that you see. But yeah, you're right. Those are probably some of those folks.
All right. I think we have time for one more quick question, and then we'll wrap it up.
Hi, my question I think is for John. My name is Carrie Appold, and I'm with Mathematica. But I'm interested in knowing if there's any plan to look at people with disabilities who may now potentially under the ACA be going into almost 2 different Medicaid programs. There might be people from, coming in through the income door that are therefore going into an essential health benefits world, and people coming in through the disability door that are going into the traditional Medicaid package. And there's theory about the pros and cons of both, but, over the next couple of years, there'll be more than theory, and perhaps a really good study population. And it'd be interesting to look at particularly the essential health benefits and how they're comprised, and whether having habilitation and mental health services over there is beneficial, not just for employment, but for a host of other reasons.
It's a great question. Are we going to fund it? I would say look to our website in 2 weeks. But I think, as I said in my remarks, we are asking some of these very same questions and are very interested in seeing what the answers might be as these programs evolve and as people make choices or are steered in one direction or another. So I think the implications are going to be significant. And I'd be happy to talk with you in a couple of weeks.
Okay, that's great. Thank you. Before we wrap up, I do want to remind everybody, John actually did this for me already, that our next forum is on February 26th. It's on the benefit offset national demonstration. And just to hype it a little bit, this is a demonstration that was first dreamed up in around 1980. And so after 34 years, we're finally getting some results. And we're inviting our collaborators from Apt Associates, Steve Bell and Howard Ralston, along with myself, will be doing the presenting for that one. So I hope to have a good turnout for that. And please be sure to complete the little survey in your packet if you're here or online about the webinar today and also your ideas for future webinars. So we hope to see you back here in February as well as past that.